Hi guys. So after discussing coronary artery disease, stable angina, unstable angina, now this is time to discuss about myocardial infarction, that is heart attack. We have already discussed about acute coronary syndromes, which mainly includes unstable angina and myocardial infarction. And this myocardial infarction is mainly of two types, that is ST segment elevation myocardial infarction and non-ST segment elevation myocardial infarction. And this myocardial infarction and angina is mainly related to atherosclerosis. And this atherosclerosis is mainly diet and lifestyle problem. See, we have already understood that this can be related to smoking, and this is also related to stress and anxiety. Therefore, you guys must keep calm and chill, but not that calm. Right. So here you can appreciate that this patient is having chest pain, and this particular sign is known as Levine sign. We have already studied in case of myocardial infarction and angina, there is diffuse type of chest pain, and patient cannot pinpoint this chest pain with help of single finger. And pain is mainly in form of chest tightness, sometimes in form of pressure sensation, sometimes in form of squeezing sensation. And main reason behind angina or heart attack is your atherosclerosis, and we have already discussed that this atherosclerosis is more of diet and lifestyle problem. So therefore, whatever you do, whatever you eat, please don't take any type of stress. Please try to chill out. Okay. And now you guys already know that blood supply of heart is by coronary arteries, and you have right coronary artery and you have left coronary artery. Left coronary artery further divides into left circumflex and left anterior descending artery. Here you can appreciate two things. See, initially there is only plaque, that is only atherosclerosis. Only plaque cannot result into myocardial infarction. Only plaque can only result into ischemia, and this ischemia can result into stable angina. We have already studied. But over period of time, this plaque can rupture, and when this plaque will rupture, it can also lead to formation of superimposed clot. Now, this clot can give rise to acute coronary syndrome, and this acute coronary syndrome includes unstable angina as well as myocardial infarction. And this myocardial infarction can be ST segment elevation or can be non-ST segment elevation myocardial infarction. The main point behind discussing this is that in case of myocardial infarction, there will be formation of superimposed clot as well over this plaque. Okay, therefore it will result into greater occlusion of coronary vessels, resulting into muscle necrosis as well, resulting into increased cardiac biomarkers. In case of angina, cardiac biomarkers are normal, whereas in case of myocardial infarction, apart from ECG changes, you guys will also get positive cardiac biomarkers. Okay, now let's again draw your romantic heart, something like this, and try to appreciate few things. This is your romantic heart. Now, this must be your right coronary artery arising from aorta towards the right aspect of heart. So this is your right coronary artery. This must be your left coronary artery. And this left coronary artery further divides into left circumflex, which will supply lateral aspect of left ventricle, and it will continue downwards as left anterior descending artery. So this is your left coronary artery, this is your left circumflex artery, and this is your left anterior descending artery, which is most commonly involved in case of coronary artery diseases. Left anterior descending is most commonly involved artery, most common in coronary artery disease, okay, resulting into myocardial infarction or heart attack. Try to appreciate few things. See, this right coronary artery mainly supplies inferior and posterior aspect of heart. So in case of occlusion of right coronary artery, it can result into inferior wall MI. It can also result into posterior wall MI. We will discuss all these things in detail. Now try to focus on left coronary artery. See, this left anterior descending artery mainly supplies apex and anterior aspect of heart. So in case of blockage of left anterior descending artery, patient might suffer from anterior wall MI or even septal wall MI. Okay. Now try to focus on this artery as well. In case of blockage of left circumflex artery, patient will mainly suffer from lateral wall MI. We can figure out all these things with help of even ECG, and gold standard for figuring out all these things will be your coronary angiography. Okay. Now, right coronary artery occlusion will mainly lead to inferior wall myocardial infarction. It will mainly lead to posterior wall myocardial infarction. Okay, we will discuss in upcoming part of slides particular ECG changes in particular type of myocardial infarction. Okay, whereas left coronary artery occlusion can lead to anterior wall MI, quite easy to understand now. It can lead to lateral wall MI. By saying lateral wall MI, I mean left lateral. Okay, left lateral wall MI, and it can also lead to septal wall MI or septal myocardial infarction. So this has to be understood because over period of time we are going to study particular ECG changes in particular type of myocardial infarction, okay, depending on the area of myocardium involved. Okay, now try to understand. We started our discussion with coronary artery disease, and this coronary artery disease is mainly due to atherosclerosis, and over period of time there will be ischemia of cardiac muscles, and this is known as ischemic heart disease. Now initially there will be only PLAB, no clot. So this will result into ischemia, and this ischemia will be fully reversible, and this will be known as a stable angina. But over period of time, this plaque will rupture, and over to this ruptured plaque there will be formation of clot as well. Suppose even after this cardiac muscles escape infarction, it will result into unstable angina. But if there is infarction, that is cell death, that is necrosis, it will be labeled as myocardial infarction. And in case of myocardial infarction or heart attack, there will be increased cardiac biomarkers along with ECG changes. We have already understood all these things. Unstable angina along with myocardial infarction is known as acute coronary syndrome. Okay, let's study myocardial infarction or heart attack in detail. Let's appreciate this characteristic Levine sign which can be seen in both angina and heart attack. And we have already studied that chest pain of angina or heart attack usually radiates, and this pain usually radiates towards the left side of heart, particularly to the left shoulder, left arm, towards the neck, and it can also present in form of tooth pain. Now try to appreciate one thing. Pain of myocardial infarction is usually more severe, more intense, more disturbing, and this can be of crescendo type. By saying crescendo type, I mean that pain intensity might increase with time even after taking nitroglycerin, even after taking morphine, and this pain is going to last for longer period of time, sometimes even more than 1 hour. Try to understand few more things. In case of chest pain due to myocardial infarction, there can be associated sympathetic overstimulation. And if there is sympathetic overstimulation, it can be associated with profuse sweating. It can be associated with more of palpitation. It can be also associated with tachycardia. It can be associated with tachypnea. It can be associated with increased blood pressure, that is hypertension. Okay, so these are characteristic of chest pain due to myocardial infarction. Patient will feel like dying, and this particular thing is known as impending doom. Okay, let's discuss further things. See, chest pain of myocardial infarction is more severe and it is of crescendo type. Now, this can also radiate towards the right side of body, particularly towards right shoulder, right arm, and even towards the epigastrium and back. Now, pain of angina mainly radiated towards left side, whereas pain of myocardial infarction can of course radiate towards left side, plus it can also radiate towards right side, plus it can also radiate towards back and towards downwards, that is towards epigastrium. This has to be appreciated. Now it is associated with sympathetic overstimulation resulting into profuse sweating, that is known as diaphoresis. It can also result into other signs like respiratory distress. Due to malfunctioning of left ventricle, it can result into pulmonary edema. And over period of time, due to malfunctioning of left ventricle in particular, patient can develop syncope. Patient can develop tachycardia due to sympathetic overstimulation. But in case of inferior wall MI, we have already discussed that due to blockage of right coronary artery, there can be inferior wall MI. In case of inferior wall MI, there can be bradycardia, there can be hypotension. Okay, patient might present in shock. So inferior wall MI presents with bradycardia, whereas other myocardial infarctions usually present with tachycardia due to overstimulation of sympathetic nervous system. And sometimes there can be sudden death due to particularly cardiac arrest or ventricular fibrillation. And sometimes more of wall of left ventricle and right ventricle can be involved, resulting into pumping failure. So it can also present as cardiac failure. Now try to understand. pain of myocardial infarction or heart attack is more severe, and it is of crescendo type, that is pain intensity might increase with time even after taking nitroglycerin. Plus there will be associated sympathetic overstimulation, except in case of right coronary artery involvement, that is inferior wall MI. Now sympathetic overstimulation will increase sweating, that is diaphoresis, will increase the heart rate, will increase the respiratory rate, will increase the blood pressure. Okay, so these are manifestations of myocardial infarction. And over to it, due to lack of blood supply to cardiac muscles, there can be pumping failure that will result into heart failure. And sometimes there can be development of ventricular fibrillation, and this can result into sudden cardiac death. It can result into ventricular tachycardia or ventricular fibrillation, and this particular thing can result into sudden death, right? Sudden death. Okay, too simple to understand. See, ischemic myocardium is more prone to develop arrhythmias, particularly tachyarrhythmias. Ischemic tissues are more excitable, okay, resulting into ventricular fibrillation, and it can also result into death. Okay, now try to understand few more things. There will be certain signs as well. Let's discuss signs of myocardial infarction. Till now, we have discussed symptoms of myocardial infarction and try to develop concept as well. See, this is your four-chambered heart, and you can very well appreciate left ventricle over here. Now, just assume that there is blockage of left coronary artery. It can result into infarction of left ventricle, and this can affect pumping activity of left ventricle, resulting into left ventricular failure. And due to this failure, there can be overaccumulation of blood in this left ventricle, resulting into dilated and compliant left ventricle. And now you guys know that dilated and compliant left ventricle can give rise to ventricular gallop, that is third heart sound. Now over period of time, these atria will also try harder to push blood in forward direction, resulting into another heart sound, that is S4, that is atrial gallop. So in cases of myocardial infarction, you can have all four heart sounds, that is S1, S2, S3 and S4. Now try to appreciate few more things. Due to this left ventricle failure, there can be pulmonary congestion as well. And due to this pulmonary congestion, patient might also develop dyspnea due to pulmonary edema. And over period of time, patient can also develop right ventricular failure followed by left ventricular failure. And when there will be right ventricular failure, there will be rise in JVP. Neck veins will also become prominent in symptoms. Okay, so these are various signs in case of myocardial infarction. Presence of all four heart sounds, that is quadruple rhythm, plus there can be increased JVP, there can be pulmonary manifestations in form of dyspnea. Right, now try to appreciate one more thing. See, sometimes due to this ischemia and infarction, there can be papillary muscle dysfunction. So this is your papillary muscle dysfunction, and by papillary muscle dysfunction you can relate that there can be problem with functioning of mitral valves, resulting into mitral regurgitation. And due to mitral regurgitation, there can be pansystolic murmur in the mitral area radiating towards the axilla. So this can result into pansystolic murmur. So these are various signs of myocardial infarction. Let's try to understand each and everything. Now let's enumerate one by one. See, there can be third and fourth heart sounds as well. This can result into quadruple rhythm. We have already studied heart sounds in a separate lecture. Plus, due to papillary muscle dysfunction, there can be mitral regurgitation. So there can be pansystolic murmur in mitral area radiating towards the axilla. Now, particularly in case of transmural MI, that is ST segment elevation myocardial infarction, there can be associated pericarditis as well, resulting into pericardial rub. We have already discussed that there can be left ventricular failure or dysfunction resulting into pulmonary edema, and it can result into presence of clefts. Now, particularly in case of inferior wall MI, due to involvement of right coronary artery, there can be hypotension and there can be bradycardia as well. Hypotension and there can be bradycardia as well. This has to be understood. Over period of time, due to systolic dysfunction, systolic BP will decrease, resulting into narrowing of pulse pressure. And anyway, due to right ventricle failure over period of time, GVP can also increase. Okay. Now, these are other signs which are related to sympathetic overstimulation. We have already studied increase in heart rate, increase in blood pressure, and more of sweating, that is diaphoresis. So we are done with sign and symptoms of myocardial infarction. Okay. Now let's discuss the differential diagnosis of myocardial infarction. See, each and every case of chest pain is not due to myocardial infarction, but at least you should rule out myocardial infarction in patient presenting with chest pain. So what are your close differentials? You have differential diagnosis. First should be your angina. It can be stable angina. In stable angina, pain usually starts during activity and it gets relieved after taking rest. Whereas in case of unstable angina, pain might start even at rest, but it usually resolves after taking nitroglycerin. Whereas in case of myocardial infarction, pain can be of more severe type and it might increase in intensity with time even after taking nitroglycerin, that is crescendo type. Plus, there will be ST segment depression and cardiac biomarkers will come out to be negative. Now, you have another differential diagnosis and this is your pericarditis. This is very important because pericarditis can also result into chest pain. Plus, there can be ST segment elevation as well. But this ST segment elevation is different from that of myocardial infarction. Try to understand this particular point. This is normal ECG, something like this. Whereas in case of pericarditis, there can be ST segment elevation with concavity upwards. Let's try to understand this. In case of pericarditis, there will be P wave and then there will be ST segment elevation, but there will be concavity upwards, something like this. So this is concave upwards. Whereas in case of myocardial infarction, there will be ST segment elevation, but it has convexity upwards, something like this. This is also known as tomb pattern. So in case of myocardial infarction, there is convexity upwards, also known as Toombs pattern. So this is how you can differentiate between ST elevation of pericarditis and myocardial infarction. Now, there can be other differential diagnosis, most importantly as pulmonary embolism. In case of pulmonary embolism, patient can have chest pain, plus there will be fall in saturation and respiratory distress. In case of pulmonary embolism, we have characteristic ECG finding, and I hope you guys already know that. There is S1, Q3 and T3. I hope already you guys know this thing. And last but not the least, there can be chest pain mimicking angina or heart attack due to GERD, that is gastroesophageal reflux disease, or due to acute gastritis. But in these cases, ECG findings will be normal, that is ECG will come out to be absolutely normal, and later on you can also go for stress ECG test and it will again come out to be normal. So these are close differentials of myocardial infarction. In angina, ST segment changes will be there, but cardiac biomarkers will come out to be negative. In pericarditis, there will be ST segment elevation, but it will have concavity upwards, whereas in case of myocardial infarction, in case of ST segment elevation, there will be convexity upwards, that is tomb pattern. And last but not the least, you have pulmonary embolism, in which you will find typical ECG pattern of S1, Q3 and T3. And then you have GERD. In GERD or gastritis, ECG will be absolutely normal. So these are close differentials. Now let's proceed. Now let's also discuss few complications of myocardial infarction or heart attack. See, we have already discussed that in myocardial infarction there will be decreased blood supply. So this can also affect pumping activity and it can result into heart failure, be it left ventricle failure or right ventricle failure. Over period of time there can be hypotension and shock resulting into multi-organ failure. Now let's also focus on this heart block. See, the conducting pathway is also part of myocardium. Therefore, in case of myocardial infarction, it can also get affected. Particularly, it can result into left bundle branch block. Okay. Now, moving ahead, it can also lead to mitral regurgitation. We have already studied that it can cause papillary muscle dysfunction or sometimes papillary muscle rupture. Due to papillary muscle rupture, it can result into mitral regurgitation. This can result into pansystolic murmur, particularly in mitral area. Now, it can also result into rupture of the septum, particularly rupture of interventricular septum, right, resulting into ventricular septal defect. And last but not the least, there can be Dressler syndrome, and this is pericarditis happening after 3 to 4 weeks of myocardial infarction. In case of Dressler syndrome, there is pericarditis, and in this case there will be again ST segment elevation, and this ST segment elevation will be concave upwards, and treatment of this pericarditis, that is Dressler syndrome, is by your aspirin. Okay, now you have one more complication, that is left ventricle aneurysm. In case of left ventricle aneurysm, there will be sustained, there will be prolonged ST segment elevation even after management of acute episode of heart attack. Okay, now one more thing, whenever there is ischemic myocardium, this ischemic myocardium is more prone to develop arrhythmia. So in case of myocardial infarction, there can be death particularly due to ventricular tachycardia or ventricular fibrillation. Ischemic myocardium is more excitable, resulting into tachyarrhythmias in particular, and this ventricular arrhythmia can be fatal, and it can also lead to cardiac arrest, quite simple to understand. Now let's proceed. See, according to this question, there is 57-year-old man presenting to cardiac emergency with chest discomfort along with fever and malaise for last 3 days. Okay, let's see. And his pain is sharp, non-radiating, plus there is pleuritic pain as well, which worsens while lying flat and improves while bending forward. Now, he is currently recovering from acute myocardial infarction 3 weeks back. So it might be delayed complication of myocardial infarction. Now let's have a look at vitals. Vitals are normal, and auscultation of precordium reveals pericardial frictional rub. So this might be indication towards pericarditis, and this particular pericarditis after myocardial infarction has to be Dressler syndrome. Now in this case, ECG shows diffuse ST elevation with concavity upwards. Now we have already studied that in case of pericarditis there can be ST segment elevation, but it is concave upwards, whereas in case of myocardial infarction, ST segment elevation, if present, will be convex upwards, right? Let's see. So this is case of Dressler syndrome, that is post myocardial infarction, pericarditis, and treatment of this Dressler syndrome is aspirin. Okay, now understand once again, in case of Dressler syndrome, that is pericarditis, ST segment will be there, but there will be concavity upwards, whereas in case of myocardial infarction there will be ST segment elevation, if it is ST segment elevation myocardial infarction, but there will be convexity upwards, something like this. In this case, ST segment will be something like this. Whereas in case of myocardial infarction, ST segment will be something like this. This is concavity upwards and this is convexity upwards. Okay. Now I suppose you guys got my point. Okay. Now let's move ahead. Now let's investigate this case. First investigation should be your ECG. Second investigation should be your cardiac biomarkers, right, for the confirmation of heart attack. Now, ECG can be of two types. See, there can be ST segment elevation myocardial infarction, or there can be non-ST segment elevation myocardial infarction. In case of ST segment elevation myocardial infarction, there will be ECG changes mainly in form of ST segment elevation. Whereas in case of non-ST segment elevation myocardial infarction, ST segment can be normal or depressed. So you have non-ST segment elevation myocardial infarction. In this, ST segment can be normal or ST segment can be depressed. But cardiac biomarkers in these two cases will be positive because we are dealing with myocardial infarction. We are not dealing with myocardial ischemia, that is angina. Now, instead of ST segment elevation, in case of ST segment elevated myocardial infarction, there can be presence of new bundle branch as well, which can mask this ST elevation. Therefore, these two findings are relevant in ECG in diagnosis of ST segment elevated myocardial infarction. Okay, too simple to understand. Apart from these ST changes, there are few other changes which are quite characteristic of myocardial infarction. See, sometimes there can be healing with scarring. So when there will be scar, it will result into formation of pathological Q waves. Pathological Q waves, that is bigger Q waves. So this Q wave will be hallmark of recovered case of myocardial infarction, which will represent scarring. Okay. So myocardial infarction can be ST segment elevation or non-ST segment elevation, and later on there can be presence of Q wave due to scarring. Right. Now try to understand few more changes. Now, along with Q wave changes and ST segment changes, there can be changes related to T wave as well. And this is even more important. Let's try to understand series of events. See, here you can appreciate ST segment elevation. ST segment elevation, if more than 1 millimeter in more than two contiguous leads, it will be very significant, and if cardiac biomarkers are positive, it will relate to ST segment elevation myocardial infarction. If this ST segment is down but cardiac biomarkers are positive, it will become case of non-ST segment elevation myocardial infarction. Now let's appreciate series of ECG changes in myocardial infarction. See, immediately after heart attack, that is within minutes, there can be T wave changes, isolated T wave changes in form of hyperacute T waves, hyperacute T waves, and this can result into tall T waves. And these tall T waves will be different from tall T waves of hyperkalemia. In case of tall T waves in hyperkalemia, there is tall and tented T wave. T wave is pointed upwards, okay? But in this case, T wave will not be pointed, it will be something like this, okay? So there will be tall T waves known as hyperacute T waves. Later on, ST segment changes will appear. In case of ST segment elevation myocardial infarction, there will be ST segment elevation, whereas in case of non-ST segment elevation myocardial infarction, there will be ST segment depression. Let's take example of ST segment elevation myocardial infarction. So within hours, there can be changes related to ST segment, and this change in case of ST segment elevation myocardial infarction will be ST segment elevation of more than at least 1 millimeter, okay? And over period of time, this ST segment will settle down along with T wave, resulting into normalization of ST segment along with T wave inversion, okay? So later on, this segment will keep on normalizing, taking T wave along with it, resulting into T wave inversion. So within days, ST segment will normalize, but it will result into T wave inversion. But weeks later, particularly after healing by scarring, there can be appearance of pathological Q waves. Okay, so these are series of changes present in ST segment elevation myocardial infarction, and these Q waves are going to persist even after patient survives, even after patient becomes asymptomatic. Okay, this scarring is going to persist. Now let's recap. Immediately after heart attack, particularly ST segment elevation myocardial infarction, there will be hyperacute T waves, that is tall T waves. Later on, there can be ST segment changes, particularly ST segment elevation in case of ST segment elevation myocardial infarction. Later on, ST segment will go down, taking the T wave along with it, resulting into T wave inversion and normalization of ST segment. Over period of time, there can be healing by scarring, and this can result into pathological Q waves. Okay. Now let's develop a major concept. See, after chest pain, be it angina or MI, you guys will need 12 lead ECG, conventional 12 lead ECG, and this 12 lead ECG comprises of 6 chest leads, that is precordial leads, and 6 limb leads. Let's write it down. You have V1 to V6. These are your chest leads. And then you have 3 bipolar limb leads. You have lead 1, lead 2, and lead 3. These are bipolar limb leads. Now let's proceed. You have augmented limb leads as well. You have AVR, you have AVL, and you have AVF. These are your augmented limb leads. I hope you guys already know all these things. Now, let's remember a basic thing. Okay, see, you have lead 2. This is your bipolar lead. This is lead 2. This is along axis of heart. That is electrical axis of heart. You guys already know that heart is slightly tilted towards left side, something like this. So this must be your axis of heart. Okay. Now, if this is axis of heart and we are talking that lead 2 is along this axis, let's draw. This must be your lead 2 along the axis of heart. Too simple to understand. This is your lead 2 and this is your positive electrode of lead 2 and this is negative electrode of lead 2. This is lead 2 as of now. Okay. And this lead at the base of heart is your lead 1. That is bipolar lead 1. Okay. This is lead 1. This is positive terminal and this is always negative. Now you guys are left with lead 3. This has to be your lead 3. This is positive terminal of lead 3 and this is negative terminal of lead 3. So you have 3 bipolar limb leads, 3 unipolar limb leads, and this is your unipolar limb lead, that is AVF. Now just try to concentrate on this diagram. These 3 leads, that is AVF, lead 2 and lead 3. So these three are inferior leads and they are looking at heart from below. So therefore they will analyze this inferior aspect better. Therefore in case of inferior wall MI, you guys will appreciate ST segment changes or Q wave changes, particularly in these three leads. This is very important. Lead 2, lead 3 and AVF have their positive terminals at the inferior part of body, that is at left leg, and they will view this heart from lower side. Therefore they will better appreciate inferior surface of heart. Therefore any ST segment change, any Q wave change will be better appreciated in these leads if it is related to inferior wall MI. Okay, so this is your inferior wall. So inferior wall MI is better picked in downward leads, that is in lead 2, lead 3 and AVF. Okay, so inferior wall MI ST segment changes or Q wave changes will be better appreciated in lead 2, lead 3 and AVF. I hope you guys got my point. Similarly, you have chest leads, something like this. This is V1, this is V2, this is V3, this is V4, this is V5, V6. You can very easily understand that these leads V5 and V6 are looking hard from lateral aspect. So it might reflect changes in ST segment or Q wave. It will be related to lateral wall MI. Similarly, these leads are present at front, okay, at anterior aspect of chest. Therefore, they will record electrical activity from anterior surface of heart. Therefore, any ST segment change or any presence of Q wave will indicate towards anterior wall MI. I hope you guys got my point. So in case of inferior wall MI, which mainly happens due to occlusion of right coronary artery, you get ST segment changes, particularly in lead 2, lead 3 and AVF. So this is your aorta, this is your right coronary artery. This is your left main coronary artery followed by left circumflex artery and left anterior descending artery. We have already studied that this left anterior descending artery is most commonly involved artery in coronary artery disease. This right coronary artery blockage can result into inferior wall MI. So if you are getting any changes in lead 2, 3 and AVF, it will indicate towards inferior wall MI, and indirectly you can figure out which coronary artery is getting involved, and that has to be your right coronary artery. Try to understand. This can result into inferior and posterior wall MI. In case of inferior wall MI, there will be ST segment changes or Q wave changes, particularly in lead 2, lead 3 and AVF, because these leads look hard from below, right? So they can appreciate your inferior surface of heart below. Okay, now you are left with left circumflex artery, left anterior descending artery. We have already studied that left circumflex artery, and we have already studied that this left circumflex artery provides blood to the lateral part of left ventricle. Okay, therefore this will be related to lateral wall MI, and findings will be mainly present in V5, V6 because these are lateral leads. Okay, now we are left with left anterior descending. This supplies blood to mainly anterior aspect of heart, particularly apex and septum. Therefore, left anterior descending artery will result into ST segment changes in many leads, particularly in V1, V2, V3 and V4, that is chest leads. These are very close to heart, so they can pick the electrical activity better. So this results into anterior wall MI. Anterior wall MI. Now, having understood the concept, now let's interpret this ECG. Always make habit of looking at lead 2 first. Okay, this is most important lead. This is along the electrical axis of heart. Now, you can appreciate ST segment elevation in lead 2. What about lead 3? Again, you can figure out that there is ST segment elevation. What about AVF? Again, you can appreciate ST segment elevation in AVF. Now you can conclude that this guy is suffering from ST segment elevated myocardial infarction, provided that cardiac biomarkers are positive. Okay, too simple to understand. So this is case of inferior wall MI, and you can also understand that inferior wall MI can happen due to blockage of right coronary artery. Okay, so there must be blockage of right coronary artery, which can be definitely picked up on coronary angiography. Okay, too simple to understand. Now let's proceed. Now let's discuss ECG bit more. You need to go for conventional 12 lead ECG. This conventional 12 lead ECG can pick inferior wall MI, can pick septal MI, can pick anterior wall MI, can pick lateral wall MI. But what about posterior wall MI? Suppose this is your heart and you have chest leads in form of V1, V2, V3, V4, V5, V6. This is your septal MI. Too simple to understand. This is your anterior wall MI, anterior wall MI, and this is your lateral wall MI. And we have already discussed inferior wall MI. What about inferior wall MI? Lead 2, lead 3, and AVF. They can show inferior wall MI, too simple to understand. Now, what about posterior wall MI? See, so you can also place these chest leads posteriorly as well in form of V7, V8 and V9, and any ST segment depression or any ST segment elevation with positive cardiac biomarkers in these posterior chest leads will indicate posterior wall MI. Right? Now let's proceed. Now let's again focus on precordial leads, that is V1 to V6. In conventional 12 lead ECG you have V1 to V6, that is 6 precordial leads. They will mainly pick up electrical activity from left ventricle, be it from septal side, be it from anterior side, be it from lateral side. What about electrical activity of right ventricle? See, for electrical activity of right ventricle, you can place two more leads, counterparts of V3 and V4. So because these are placed on right side, you can label it as V3R and V4R. Any ST segment change or any Q wave presence in these leads will indicate towards MI of right side. Okay, now for posterior MI, we have already studied that you can also place few leads posteriorly, that is V7, V8, V9, right? They will indicate towards posterior wall myocardial infarction. Okay, too simple to understand. Now let's capitalize on this knowledge. Let's take anterior wall MI first. Anterior wall MI. And let's also keep things very simple. This will be better reflected in form of ST segment changes from V1 to V4. What about septal MI? Septal MI will be best reflected in V1 to V2. What about lateral wall MI? Too easy to understand now. Lateral wall MI. This will be better reflected from V5 to V6. Sometimes proximal part of left coronary artery gets involved, resulting into involvement of larger area. This particular thing is known as extensive anterior wall MI. And by common sense, you can relate that ST segment changes will be present from V1 to V6. Okay, that is in every chest leads. Now, you are left with posterior wall MI, you are left with inferior wall MI. We have already discussed that inferior wall MI can be best appreciated in lead 2, lead 3 and AVF because these leads look your heart surface from below. Okay, now what about posterior wall MI? Posterior wall MI can be better appreciated in posterior chest leads, that is ST segment changes in V7, V8 and V9. This particular chart is very important for localization of myocardial infarction. Okay, that's all. Now let's recap. See, now it has become very easy for you guys. Any ST segment change in lead 2, lead 3 and AVF will reflect inferior wall MI. Now this has become very easy to understand, and this might be due to occlusion of right coronary artery. Similarly, V1 to V4 will reflect your anterior wall MI. Plus this has septal component as well, that is V1 to V2. So you can also call it antero-septal MI. Okay, if it is only V1 to V2, you will call it septal MI. Now V5, V6 involvement will reflect lateral wall of left ventricle, therefore this is lateral MI. What is V4R? That is chest lead placed towards right side of heart. So this will reflect MI involving right ventricle. See, confirmation of myocardial infarction is not by ECG. It is actually by cardiac biomarkers. But treatment has to be initiated on the basis of ECG. And we have already studied cardiac biomarkers in previous lecture. And we did study that heart fatty acid binding protein is first cardiac biomarkers to increase in case of myocardial infarction. And we have also studied that nowadays we mainly go for troponin levels, particularly troponin T and troponin I. And this troponin I, that is trop I, is more important for the diagnosis of reinfarction as well. So for discussion of cardiac biomarkers, you can refer the previous lecture. Okay. Let's now discuss clinical classification of myocardial infarction. See, we have been studying atherosclerosis in detail, and there can be rupture of plaque resulting into formation of superimposed thrombus. This results into spontaneous myocardial infarction, and this is type 1, that is typical myocardial infarction. But sometimes, even though there can be no rupture of plaque, there is atherosclerosis, but clot has not ruptured, but patient has suffered from anemia. Patient has suffered from vasospasm, so it can result into mismatch of oxygen demand and supply. And over to this atherosclerosis, patient can suffer from MI even without rupture of the plaque. Okay, so this is type 2, that is due to mismatch of oxygen demand and supply. Type 3 MI is that MI in which probably death has occurred due to MI, but you could not send cardiac biomarkers. Before sending cardiac biomarkers, your patient expired. Type 4 is related to percutaneous intervention, that is your angioplasty, and type 5 is related to coronary artery bypass graft. So how you are going to memorize all these things? Let's make a mnemonic. Okay, now you have 5 types of myocardial infarction on the basis of clinical classification. First is myocardial infarction. This is due to atherosclerosis followed by plaque rupture, that is followed by clot formation. This is typical MI, this is type 1 MI. But in second case, there is atherosclerosis, but there is no clot. There can be spasm of blood vessel, or there can be other reasons related to anemia. So this results due to problem with oxygen supply and oxygen demand. Whereas in third case, there is sudden cardiac death, and this sudden cardiac death will not allow you guys to send the cardiac biomarkers. Type 4 is due to percutaneous intervention. Type 5 is due to coronary artery bypass graft. How to remember all these? Let's have a look at mnemonic. You have heart attack in deadly police cab. Deadly police cab. Okay, now just try to memorize this mnemonic. Heart attack in deadly police cab. Heart attack means we are dealing with myocardial infarction. Attack means you have type 1 myocardial infarction, which is related to atherosclerosis. Atherosclerosis plus thrombus formation. In means there is imbalance between oxygen demand and supply. Deadly means patient has expired even before you could send the cardiac biomarkers. Okay, not sent. Whereas in case of police, you can understand that this is related to percutaneous intervention, complication of percutaneous intervention. And in this case, cardiac troponins will increase 5x from the baseline. And last but not the least, you have CAB. CAB is related to coronary artery bypass graft. This can also lead to iatrogenic myocardial infarction, and now cardiac troponins will increase approximately 10 times. So clinically, you have 5 types of myocardial infarction, and this can be memorized with help of heart attack in deadly police cab. Heart means myocardial infarction, attack means atherosclerosis plus thrombus, in means imbalance of oxygen, and then deadly means patient has expired even before you could send cardiac biomarkers. Police means related to percutaneous intervention, that is angioplasty. Last but not the least, cab means coronary artery bypass graft. Okay. Now let's finally discuss treatment of myocardial infarction, particularly ST segment elevation myocardial infarction. We have already discussed treatment of unstable angina and non-ST segment elevation myocardial infarction in previous lecture, and we did mention that in these two cases thrombolysis is contraindicated. I hope you remember all these things. Now, let's focus on ST segment elevation myocardial infarction and again employ Mona darling. And in this Mona, aspirin is given in high dose, and this aspirin is usually given in dose of 325 milligrams along with another antiplatelet drug, particularly you can give clopidogrel, and this has to be given in strength of 300 milligram tablets. And apart from all these things, you have to also give beta blockers to decrease the heart rate, to decrease the sympathetic activity, along with ACE inhibitors and statins. We have already discussed all these things in previous lecture. But in case of inferior wall MI, beta blockers should not be given, because in case of inferior wall MI, there is already bradycardia, and bradycardia will further worsen if you happen to give beta blocker. Okay, now let's proceed. Here you can appreciate beta blocker, that is atenolol. Metoprolol can also be given. Along with those, you can give ACE inhibitor, you can also give statins. So you have Mona darling along with ACE inhibitors, statins and beta blockers. Okay, now let's discuss the definitive management. Suppose you have stabilized this patient and angiography was done, and in angiography you figured out single vessel disease. Definitely you are going to do percutaneous intervention or balloon angioplasty. Suppose you find triple vessel disease. Now CABG will be superior as compared to percutaneous intervention. In case of chronic stable angina, you can decide whether to go for percutaneous intervention or CABG after some time. that is elective procedure. Whereas in case of unstable angina and non-ST segment elevation myocardial infarction, PCI or CABG can be done urgently. Whereas in case of ST segment elevation myocardial infarction, percutaneous intervention or coronary artery bypass graft has to be done in emergency. Okay, ideally, because this is most dangerous type of myocardial infarction. This is transmural type of myocardial infarction. Okay, but what is the timing and what are the indications of PCI and CABG? We are going to discuss. See, ideally percutaneous intervention, if that facility is available, has to be done within 90 minutes of arrival in the hospital. But if it is not available, you can go for thrombolysis, and that has to be done within 30 minutes of arrival into the hospital. Okay, now let's see. See, there are guidelines for reperfusion therapy. As already discussed, that door to needle time, that is ideal time for thrombolysis, is within 30 minutes of arrival. Whereas door to balloon time, that is ideal time for percutaneous intervention, if available, is within 90 minutes of arrival, that is door to balloon time. But it can be done as late as 12 hours in case patients arrives very late. Okay, now let's proceed. So door to needle time, that is ideal time for thrombolysis, is within 30 minutes, particularly if PCI facility is not available at this hospital, and you can employ streptokinase, alteplase, or retiplase. So these are tissue plasminogen activators which will dissolve the clot, okay, with help of plasmin. Whereas door to balloon time is ideally within 90 minutes, that is for percutaneous intervention, that is your balloon angioplasty. But we did discuss that this can be done as late as 12 hours. Okay. Now, this is result of angiography. In angiography, this is gold standard test in picking up the obstruction in the coronary arteries. Okay. We have already discussed all these things. So, this is your balloon angioplasty. And here you can appreciate that there is balloon which inflates and breaks the plaque, and this is your stent. And nowadays we are using elutants to prevent re-stenosis at this stent area, and these elutants are sirolimus, biolimus, and sometimes paclitaxel as well. We have already discussed all these things in chronic stable angina, but sometimes percutaneous intervention is not enough. Therefore you have to go for coronary artery bypass graft, that is bypass surgery, particularly when there is triple vessel disease or when there is left main artery disease, that is left coronary artery is obstructed right at the starting, that is right at the proximal part itself, or there can be double vessel disease and there are multiple obstructions at multiple levels. So you have percutaneous intervention and coronary artery bypass graft as options. Okay, and in CABG you can employ vein as well as artery. Most common vein employed is your saphenous vein. Most common artery, which is in fact superior, is your internal memory artery, followed by radial artery. That's all regarding discussion on myocardial infarction, particularly ST segment elevation myocardial infarction. Bye bye.